Out of Spain's 40,000 cases of coronavirus cases, we have 5,400 actually affecting healthcare professionals. The same is pretty much true also for Italy and the rest of the world. There are 37 Italian doctors we know to date which have actually died from coronavirus. And we know that we have 3 more cases which actually occurred just in the last 3 days, and one of them is actually a very good colleague of ours. He is the head, or used to be the head of the European Society for Cardiovascular Imaging, the vice president there, and he just recently died in Naples. Of course, if we hear these figures, it really gives us shivers, and we know that we as healthcare professionals are at the forefront here and very much, of course, in the risk situation of maybe also being affected. But being affected not only means that we die or get sick or might even have an illness that will have long-lasting effects, but it also means that we cannot give care to the others, and it also means that we are people who can infect others. So these are some of the things we will discuss in the webinar, something that is very much on my mind, and I think in all of you, and I'm very, very happy to have speakers with us from all around the world where we'll discuss this topic, but also the topic of how can we protect ourselves, what can we do to manage the patients correctly, and we will also focus on a very, very important topic, namely on point-of-care ultrasound, which in this situation might be a very good diagnostic tool, and we'll discuss that in more detail in COVID patients. So let me introduce to you, of course, Martin Altersberger. Martin Altersberger is one of the, I would say, young generation doctors. He is someone who's learned ultrasound very, very early on in his career, and he's pushing this technology forward, and I'm very happy to have him with us. Then we have, of course, Dr. Jalal, who is from Texas. He will give us his perspective on what the situation in the moment in US and of course also in Texas is. He is someone who's working very, very heavily now also in preparing everything for the number of patients which we hope not, but probably will also come to the US and to Texas. And then we have from France, from Paris, Jean-Jacques Rouby, who is an expert in pulmonic ultrasound and also in intensive care medicine, and he'll give us his perspective. He'll also talk more together, of course, with Bilal on the topic of point-of-care ultrasound. But before we go into these topics, let me just talk a little bit about the current situation and just start by giving you some statistics which I think are very, very impressive and important to know. And I think many of you have seen these statistics. Those are the trajectories of cases in different countries. And if you look at these curves, you will realize that different countries have different rises of cases, which essentially also means that the mortality will be different in different cases just based on the numbers that we see. And if you take a look at this statistic, you will see that China is now flattening off. But you see that we have other countries which have an even steeper rise, and we know the situation in Italy has been devastating, in Iran. Now Spain is very much on the rise, and we have US who just surpassed even China with number of cases. So this is in a way something that is worrisome, and if you pick out some of the countries some of the cities or regions we're looking at, we see that actually Madrid is now almost in par, if not even surpassing Lombardia as the region which has the most cases. And what is also very, very worrisome is the fact that there are some countries which might have an even steeper trajectory. We have to be cautious because the numbers and the data and the statistics is of course very difficult to compare simply based on the fact that the number of people we test varies from country to country. But if you just look at some countries such as Turkey here, or if you look maybe at countries as maybe Poland or some others, they are certainly in a situation that they might come to a very similar situation as those regions that are now so much in the news. So I would like to first discuss a little bit what the experience in the various countries is, and maybe we can have first Jean-Jacques report a little bit about what the situation at the moment in Paris and in France is. We know France is also being heavily hit, and we see rising numbers there as well. Jean-Jacques, can I have your review or your impressions?
30,000 people contaminated. Among them, we have more than 3,000 that are considered to have SARS-CoV-2 pneumonia, but non-critical. They are staying either home or in the hospital. And we have 1,600 patients admitted in intensive care units. But you know, the situation is not really homogeneous, in France. East and Île-de-France, the region of Paris, are heavily contaminated. South, west, west, northwest are really in a quiet situation. So the fact that we have two regions that are massively involved with the outbreak raises very specific problem. In these regions, hospitals are either overwhelmed, ICUs, by critically ill patients, or like in Paris right now, just on the limit. So we think that we have in Paris 200 beds that are still empty. And we think that in 1 or 2 days, they will be occupied by patients. So then after, what are we going to do? One solution is to move physicians from other regions of France to Paris and East, like was done in China. You know, many of our Chinese colleagues went from different provinces to Hubei. In France, it's going to be difficult to do that. So the other option is to move patients to ICUs, patients from Île-de-France or east of France towards ICUs in west and southwest. Yesterday, there was a fast train, a TGV, that was that transported from Mulhouse in the east part of France to Tours, middle west, 25 critically ill patients to the ICU. So we don't know exactly what is going to do, but right now the ICUs are working. We have a sort of war organization in the ICU to have enough doctors, enough healthcare providers, and also to permit the other to rest. This is very important because it is a tough job. So let's say it is under control, and in 2 or 3 days, it's going to be difficult imposing solutions.
Patients, when would you think you would reach the maximum of patients?
3 days, 4 days, 5 days, we don't know exactly. Let's say beginning of April.
Okay. Well, maybe
Paris, France was constrained 10 days ago. So if compared to Italy at the same period, according to the beginning of the outbreak, we are 1 week in advance. So we hope that the curve you showed coming from John Hopkins, it seems that France is a little bit under Italy. And so we hope that the confinement en français, is going to reduce the number of critically ill patients to admit. Let's see what happens.
On a personal front, in your hospital, are you seeing a lot of patients, and can you describe how these patients present? Is it exactly as you would see them from Italy? For example, do you see younger patients? Do you see many patients being admitted to the intensive care?
We admitted 35 patients. 17 died. So the mortality rate once the patient has been intubated is like in China, around 50%. So it's a terrible situation. Most of the deaths were observed in elderly patients over 80 with severe comorbidities. And let's say that 70% of deaths were related to the decision of the medical team and the family on phone to stop the ICU support. It was the main cause of death. The mean age is 60. It means that we admitted patients from 35 to 87. But we have already relatively young patients in the ICU. They are still ventilated. We did not observe one death in these young patients, but the mean duration of stay in the ICU for SARS-CoV-2 pneumonia is 2 to 3 weeks. So we have to wait to see what will happen to these young patients.
Of course, this is also a problem with respect to the resources. If patients are very long on the ventilators, you cannot get the ventilators free for new patients, which I also see as a big problem. Maybe you can also comment on the question whether or not you see a problem within the healthcare community population. A lot of cases among doctors and nurses. Do you see, of course, your staff being affected?
What we know from China, it was published. The risk of contamination of healthcare providers in wards, emergency wards, infectious disease wards is high. In China, in Wuhan, during the first month, 38% of healthcare providers in these hospital wards were contaminated. And there was also a high rate of non-COVID patients contaminated. In the ICU, it is much less. In Wuhan, the contamination of ICU health care providers was around 5%. In our ICU, we do not have yet one contaminated doctor or a nurse. Why? Because in the ICU, we are used to protect ourselves, and the protection is total. So it makes a part of the difficulty, because to enter a room and to go outside takes time, because you have to wear and unwear a suit, sterile suit, gloves, wash the hand, put a helmet with, But again, the contamination of a physician in the ICUs is very low. So the risk is in hospital wards. Because before being admitted to the ICU, part of these patients are admitted to the emergency ward, and then they worsen, and then they go to the ICU.
Yeah. I would like to come to Dr. Bilal now and maybe have his take on what is going on in Texas at the moment. We know that New York is heavily hit, but what about the situation in Texas?
We are currently seeing the storm hit the shore. And what I mean by that is we're just going to start seeing these numbers uptick. If it's possible, if you could get my slides on there, there's some slides I have on Texas specifically that I wanted to, or the United States in general, but Texas specifically. But we are projecting that we're going to be getting short on healthcare resources going forward. I think the next couple of weeks are going to be very tough for us. As far as the, I think very similar characteristics of patients who are not doing well are those that who have comorbid conditions or have advanced age. Those are the people that we've seen get in trouble. The risk of cross-contamination, and I agree with Dr. Ruby, in the ICU, we're so used to making sure we're protecting ourselves. We're using N95 masks or PAPRs. We have gowns and gloves and a lot of protective gear that right now we're doing okay on. I don't know if going forwards in the future we're going to start running into shortages. I know some hospitals in the United States and specifically Texas have started reusing face masks even, just because we're projecting we're going to run out short of supplies.
So I think we can see your slide now.
Yes. So this first slide, what I meant to show on this was the blinking map that you can see. That map is showing the red dots are the total cases that have been diagnosed, and then the there. So I feel like it's a reliable source. And then the map is from Johns Hopkins Command Center. If we go to the next slide real quick, please. And this is focusing now only on the United States. And obviously there are 4 states that have been hit the worst with the virus. New York, the news has it all over. I know for a fact that there are some hospitals in New York that have a critical shortage of ventilators. They've actually started splitting a ventilator to use one ventilator for 2 patients. But New Jersey is a neighboring state to New York that's been hit fairly significantly, not nearly as bad as New York. Texas on this list is at number 11, still barely above 1,500 cases, but that number is climbing very quickly. We're short of New York, where I think we're rising fairly fast. And go to the next slide, please. And this is from the New York Times that I pulled, kind of comparing data for the US and Italy. And you can see how on a linear curve, it doesn't really depict it so well. But when you go to a logarithmic scale, you're seeing the rate of change a lot better. And you can see that that curve in Italy is kind of flattening out. This data is obviously a week old from the New York Times, but we can still see a week ago the US was still on a steep uprise. And then when you go to the next slide, you'll be able to see that that data point that I talked about, tracking serious critically ill patients in the world. This it's very interesting. So I updated this slide yesterday, and I did make some changes to the presentation this morning because the statistics had changed significantly. Primarily that the U.S. had taken lead on the number of cases worldwide. But this graph was at 15,000 yesterday. when I downloaded it. And today, when I looked at it, this is up to 20,000. So we have 5,000 new cases that are critically ill. On the right of this graph, you can see this is from Forbes, and they're kind of giving us an estimate of how many ICU beds we have per capita. And despite the United States having one of the highest number of ICU beds in the world, we still also have a fairly high utilization of ICU beds. And we will eventually come to the point where we're going to run out of ICU beds. New York has already gotten to that point. I think there's some naval ships being moved there that have hospitals on them that they can take care of patients on over there. But this is coming. This is going to keep rising, these numbers.
Those are really, really, of course, scary numbers. Just for the audience out there, we had a little bit of a break with the audio for 20 seconds, just for all of you who did not hear it. But I think the key points are that the numbers are rising very quickly in the US and, of course, also in Texas. And there seems to be more and more patients coming into a critical situation. And you do also expect that you will come into a situation where you do not have enough critical care beds.
I think very interesting question. So I'm going to share my screen with a separate window that I've opened up. And this is a website that's kind of tracking the utilization of hospital resources in the United States. And you can see it's very funny that on April 14th, that's my birthday, but on April 14th is the day that we're going to actually run out of critical care beds in the United States. For Texas, that changes to April 14th. Obviously, this is still a projection, but you can. This is data that is being formed by big data and the analysis of large numbers. I would believe this until that curve flattens.
Yeah, this is really, really worrisome. With respect to the whole issue of ventilators, you were even mentioning that you're using a kind of a T to ventilate two patients at the same time. Do you expect the US to ramp up with the amount of ventilators? I know there's a lot of efforts now within the industry where certain industries which have never really produced medical equipment are now all of a sudden trying to produce ventilators. Or do you think that this effort will simply come too late?
The first part of that is that even the companies that are ramping up creating ventilators, are they the ventilators that we use every day in an ICU where you have multiple different modes, hybrid modes and other different modes? Are these going to be just CMV ventilators that are not going to be very useful, in fact may harm patients? It's very hard to tell until we start using these ventilators that are pushed out very quickly. At the same time, splitting ventilators is also, it may work in a short run. I think it works best in mass casualty, mass trauma situations where you have healthy lungs, but you have a lot of people who require critical care. In patients who have ARDS, and you have different varying compliances of lungs on an hourly basis, having patients being split on ventilators is eventually going to harm patients. And I also very strongly feel that the more the critical care part of healthcare gets overburdened, our outcomes are not going to be as good as they are for patients when we're taking care of a few patients, as opposed to having 40 more patients that I'm taking care of that I'm not used to. And so I think all of those will play into to factor in. We'll see.
Okay, I think we'll talk much more about the management of patients, because I see we're getting a lot of questions in that I definitely want to pitch to you. But this is a final question before we move on to maybe Martin and let him give his take on South Korea. You'll hear why he's going to talk about South Korea a little bit later. But my question to you is, did we react too slowly? Should we have been faster in the way we reacted, or would have been unpreventable anyway?
So I think, I'm not sure if that would have absolutely helped. I do think that as far as the United States is concerned, we should have thought about shutting things off a lot sooner than we did, and I think that may have protected us, because we have to realize there's a 5-day incubation period, and then there's 5 days of me carrying the virus around, give or take. So that's a 10-day lag period that you're going to see. So from when a shutdown is implemented, everything you see in the next 10 days is actually what happened before the shutdown went in place. So we still haven't seen what the effects of limiting social distancing and all those kinds of things is going to show us, and we'll find out in the next few days.
And last question, maybe, what about the healthcare personnel you have? Do you have the resources you need, or do you think that you'll run short on them as well? Do you see infected cases in your hospital?
So we do see infected cases at our hospital. When we started off, every patient that was even being suspected to have coronavirus was being placed in airborne precautions in a negative pressure room with a PAPR or a face shield with an N95. The CDC changed their guidelines about a month or a month and a half ago to where we can start using a surgical mask with a gown and goggles or a face shield. And so that's made healthcare resources be a little more available for everyone. But we're going to run short. If this doesn't end soon, no healthcare system is prepared for this kind of a burden to their system.
Okay, well, thanks a lot. We'll come back to some of these issues a little bit later, but maybe we'll have Martin now. Martin, what is the situation in South Korea?
With saying why I'm talking about the South Korean situation. So my wife is South Korean, and of course her whole family lives in South Korea, and I hear every day how they are dealing with the COVID-19 situation. And maybe Tommy, if you can open my slides, then we can start. In the meantime, okay, thank you very much. So I found quite a nice and interesting article about contact transmission of COVID-19 in Korea and tracing contacts. And what the authors are describing is that we are facing an, for now unknown, or at that time unknown, infectious disease. And for an unknown disease, you have to determine the prevalence to explore the cause. Now we know it's a viral disease. Explore transmission, and of course then prevent transmission. And we do know that individuals become the source of infection, and person-to-person transmission is of course suspected. It is very important to identify the patient or the possible patients and appropriately manage the people. So if you can go to the next slide. As I said, we have to classify the contact persons, evaluate the exposure, and also think about the possibility of environmental contamination and disinfection the area. And if you go to the next slide, this is the web page of the South Korean government on COVID-19 cases, and it's updated on a regular basis, so more times a day or several times a day. And thankfully, as I'm also not that fluent in Korean, there's an English version of that page. And here, just keep in mind the graphic we see in the middle. Can you go back just for a second? In the middle, we see South Korea, and the red areas, those show the infected cases all over South Korea. Next slide, please. Here we have the English version of the page, and it is quite nicely displayed that you see the confirmed cases. And in Korea, today there were 9,332 cases confirmed, deceased 139 patients. And if you look at the tests performed, there were 377,000 tests performed in South Korea since the outbreak started. So there's a lot of testing going on in Korea. And if you can go to the next slide. Here you see how the Korean government communicates also to the people how they are planning to quarantine and how quarantine worked, and that there's a central disease control headquarters, of course, and the measurements or the measures are directed to local municipals. if you go to the next page, in Korea, it was from the beginning very important to prevent the inflow and the spread of the infectious disease. So they set up quite strict rules on how to deal with patients or people coming back from other countries. And one of those measures was everyone who enters the airport and enters Korea, they have to install an app. And if you go to the next slide, this was a very simple app, and you had to download it, and you had to monitor your symptoms and your health status 14 days. So every day for 14 days, you had to document if you had fever more than 37.5 degrees, or the feeling of having fever, coughing, or dyspnea. And this data is available for the government, and then they were able to deal with patients individually. And if you go to the next slide, that is a very nice image. I think it's how early detection of infected patients happened in Korea. They set up specific drive-throughs, so screening centers, and in the second picture you see a car, and how the testing was made. It's just everything happens in the car. So the people or possible infected people with COVID-19 keep the distance. So social distancing was very, very popular or important there. And if you go to the next slide, as soon as someone was infected or confirmed with COVID-19, this is an example of Seoul. And in Seoul, you saw the personal data was stored, so the nationality, the sex, the year of birth, not the exact date of birth, the route of transmission, and the confirmed date of the test being made, and where the patient is a resident, and also where the patient is isolated. And what's more important or even more interesting is that there's a specific patient's movement path. So the Korean government used asking the people where they went. They also used the GPS data, and they also used the so-called CCTV. So that's kind of like a closed circuit television. It's a security camera system all over Korea. And with all this information, they restored or created all the maps where COVID-19 patients were. So you know when you had contact with those patients. And if you go to the next slide, here you see a detailed information about each and every dot. And so the slide we are now is an example of Busan in Korea. And you see the same information displayed. And now we are back at the map of Seoul, and you see each and every dot had a specific or has a specific kind of information where this person was infected, where this person was. And if you are infected as well, you got a message via an app so that you know that you were or you are possibly contaminated, and then you are invited to checkup. And in the next slide, we see the same example. So every region has a different web page, and it is displayed basically the same. So you always have the personal data with year of birth, the sex, the residency, the route of transmission, the number of people you contacted, the isolation facility, and the confirmed date of when you were infected. And the aims overall in Korea was to create accurate information. So if you go to the next slide, and especially minimize the fear and the confusion of the inhabitants, and to also still to have a protocol to protect the privacy of the patients as well. So that summarizes basically what was done in Korea.
Well, I can only say this is very, very fascinating to see how they are using digital technology to fight the battle against COVID-19. Of course, you know, the technology definitely is there, and they were just quick enough to utilize it. Especially, they also used a lot of testing And maybe I'll just pitch the question to maybe to you, Balal. What are your thoughts on, should we do more testing? Do we do enough testing?
I personally think testing has two things that it changes your management from, right? One would be that you isolate that patient. If you test them, then they test positive. And the second is you add to a statistic. So the numbers that we're accumulating, because there isn't, and we can talk later about treatment options, but there isn't very good treatment available for coronavirus. In fact, for most viral infections, the treatment is supportive care. So testing the appropriate population, I absolutely agree with. If over testing is with an intent to limit the movement of those patients, absolutely that would help. But if testing is only being done to add to a statistic and there's nothing more that's happening after that, I don't necessarily know that would be helpful.
I mean, one topic which has been very much on the mind of doctors, especially in Austria, because I've been following along the social media here, is should we test all doctors? Is that something we should do? Because, as we discussed earlier, we are a risk group.
Right, and one of the things that concerns me is it could be two-faced. It could be great in a way that, you test the hospital, 30% of your staff is positive, right? And so you get all of those staff members out of their workplace, and now you've got your 70% of your force of healthcare workers that's taking care of 200% of a patient load. And so unless healthcare workers have symptoms, I personally don't think we should start testing everyone. It's counterintuitive in some aspects, because you could be someone who's contaminated and you could contaminate other healthcare workers. When we see patients, we're taking all precautions, and that should not permit any transmission of infection from doctors to patients. But the healthcare workers absolutely are at risk.
Yeah, it's certainly a very controversial topic, because we as doctors definitely want to know if we're at risk or not. And when I was talking to some of the colleagues from Italy in the previous webinar we held, where we had some Italian colleagues with us, they said, well, as a matter of fact, they don't test us anymore because so what? We're probably all infected anyway. Only if they really become symptomatic with progressive symptoms, not even mild symptoms, would they be tested. But then again, of course, my thoughts are, well, you've got these people running around. They go home, they go to work, they meet other people, they work within their doctors, colleagues. So this is, of course, a threat that I see, because definitely, we'd, of course, spread the infection to the whole medical community. And after all, we're their caregivers. So this is something that, it probably is a little bit of risk. But again, it's a very controversial topic, and I agree, especially given the fact that we do not know exactly how high the sensitivity and specificity of the test really is. Yeah.
And it's interesting because my wife is a pediatric cardiologist. She works at a children's hospital, and I work in an adult hospital. And so I come home from my ICU, which I may have had contact with patients who have COVID. I'm going to give it to her, and then she gives it to the kids that she's taking care of. Obviously, we know that kids are not as bad as risk, but if we infect enough kids, I guess we'll find out, and that's scary.
Yeah, absolutely. I mean, it's this chain which is so sometimes difficult to see, especially when, again, coming back to some of the colleagues in Italy, and I was discussing the question of why they have such a high mortality. And I think it's also the way the Italians are organized in their social culture. It's they closed the kindergartens down and they went straight to the grandparents, and that's who were the caregivers for the ones who took care of the kids. So obviously the infection spreads via these channels, and sometimes we have to be aware that there's a lot of traces we're leaving in the dark without even knowing who we're infecting. So in essence, I think it does play an important role to know who the people are who are, of course, infected. But let me now move on, and I would like to just simply present China, because we have very strong ties to China over many routes. From our platform, we have a lot of people who are users of our educational content, and through our hospital, we have a lot of Chinese nurses. And We have, of course, Dr. Hong, who gave me a lot of information here, and I was discussing this for the last 3 or 4 days, and she was giving me a lot of insights, together with Dr. Wang, who is in Shanghai now. And I think what is so important, and this is maybe very similar to what Martin presented in his lecture on South Korea, we can really learn from them and see how they mastered actually this crisis. And this is a very short video where I'd like to present to you, which Dr. Wang made, just to show how they cope with the situation now that the virus has, I would not say defeated, but at least pushed back, because definitely they're afraid that there's going to be a second wave coming. And this is how they protect themselves from the second wave.
Okay, now let's follow me. Here is the office. When you try to use in the elevator pushing the buttons, you need a pen. The elevator has been cleaned 3 times a day. There is disinfectant outside the elevator. Using keys to open and close the door. Packages and mails used to put here, now we change places. Pregnant women using the special pathways. We have 7 big entrances like this, but nowadays only 1 for patients to come in and go out, 2 for staffs. Here is the outpatient department. Patient needs to make an appointment to come into hospital. And there is a temporary tent for the temperature testing, and the patient will report their history. Here is the emergency room. We also checking their temperature. There is a special building for the passengers from Hongqiao Airport. When they have suspected symptoms, they're going to quarantine here. Fever clinic is here. It's totally isolated from the other ward and other clinic. When patients have the fever or suspect to have coronavirus disease, they're sent here. Patient family needs doctor's permission to come to the inpatient department. Now we put the packages and mails in that house. I usually could go out and get through this entrance, but today I could only go in from this entrance and couldn't go out through this. Surgeons work in this building. When the disease spread, we only do emergency surgeries, but nowadays it came to normal. Because the proper rate protect, we don't have doctors getting infected of the coronavirus disease in our hospital. And we have faith in conquering all this. I wish you all good luck.
Yeah, well, I guess we can definitely need all the luck, and I can only congratulate China with initiatives of course, fighting the battle, and at the moment at least being on top of the virus. As Jean-Jacques mentioned, I was told they brought in 25 to 30,000 nurses just to fight the battle from different regions. So it was almost like a new army moving in. Jean-Jacques, maybe let me ask you, is this something, or the precautions they're doing there, is that something very similar to the way that you're trying to prevent more cases from coming?
It's too late, I guess. In east of France and Ile-de-France, it's too late because the number of contaminated patients is very high. No, 300,000 people with symptoms that were found contaminated. So probably the total number of people contaminated is threefold. It's not the case in other regions of France. In fact, we have clusters. East of France, Ile-de-France, like we have cluster in United States, New York, California, Washington. So maybe the way to control the outbreak when it is starting in some part of the country is different. Maybe we should use the Korean way to do it. And in regions with a large number of contaminated people, the only way is to shut down and keep a minimum of economic activity with facilities for healthcare providers. I think we have a problem with sound.
Yeah.
Okay.
I think that is definitely something that I probably would agree with. And again, coming back to what you mentioned too, the digital technology, this is also being very strongly applied in China. And I can just show you here on my slide. You can see that they use the QR codes. If you go into an entrance, they have the apps. They know, of course, much better where someone has been within the last 14 days. And they can control much better and see who is actually the patient who is arriving. So this is a very, very important part of the prevention program in China. And I believe that this is something that probably could be initiated in many countries, Western countries or Eastern countries that are now strongly affected by COVID as well. So this is definitely something which is important. But the other thing which is very important as well is the protective clothing. And this has been a big issue. You've mentioned already that there's a shortage of personal protective equipment, that we're hoping to get more of that equipment soon. But it's very, very important also that you know how to wear this equipment. And there's now a lot of initiatives that are trying to teach people, once the equipment is here, how to really, really use it. I will show you a video, which is an official video from China that demonstrates just in principle how it should be done. This is just a short version of the video, but I think it also gives you a little bit of a feeling of how strictly these things are organized in China.
穿防护用品有遵循的程序：7步洗手。戴医用防护口罩。 穿防护服，一定确保拉链全面，胶带严密。脱防护用。
So this basically is just an example of how these programs are used to train the people to put their clothing on, and even more important, to take it off. We from One to Sonography are now working on a project as well, where we are going to film and provide a video tutorial for everyone who is involved to learn more about the hygienic aspects of it. So we're working hard, hoping to finish production within the next week, and so that we can give this lecture to all of those who are involved. I think it's a very important aspect of protecting ourselves that I think is also on the forefront of our intentions. And just to show you another video, it's also very important to get a bit of a feeling of how the situation there is. And this is now a video demonstrating just the environment that the people are working in.
进入到我们吉林省支援湖北首批医疗队他们工作的区域。截止到今天啊，我们这支医疗队呢已经来到了湖北整整60天。我们的医生们呢在这里一共接诊了109名新冠肺炎的患者，其中呢有一个好消息，就治愈了100例。
我省支援武汉首批重症救治医疗队是由呼吸科、感染科、感控科、重症医学科等相关专业的137名医护人员组成。1月28日起，在同济医院中法新城院区 C12层东区接诊新冠肺炎患者。
稍后啊，疗区仅有的3名患者呢，将被调配到综合内科，也是其他的科室进行进一步的治疗相应的基础疾病。那么今天也是我们的这些医生在这里工作的。
So basically what you're seeing here is you're seeing the so-called half-sterile room, because you have to imagine that it's also important to build a pathway into the area where the patients actually are. So you have to have, of course, a lot of, I would say, logistics in place. So yes, you will have a region, and this is the region that you can see here marked in yellow, which is completely clean and sterile. This is where the patients would go. And then you have a halfway infected place. For example, if you go in and you want to dress, you need to have these different step approaches. This is how China is working, and this is a map which actually came from a Chinese hospital, which is now translated so that I can understand it. But it's important that there's more to hygienics than just the clothing. It's also how actually to do it. And the third part is the clothing itself, to have a protective equipment. And here we have logistic problems at the moment in many parts of the world. As a matter of fact, a lot of the equipment that is needed is now being produced and being provided. And we in Austria are in a, I would say, relatively difficult situation as well. Unfortunately, we had good ties with China, and when the situation was really, really bad in China, we brought equipment to China, and China is now helping us and bringing us some equipment back. And this is an airplane. You can see it's an Austrian airline plane where we have packages of equipment which is now being flown into Austria so that we can satisfy at least partially the needs of the hospitals. But this does bring me also to the situation in Austria. And we in Austria, I think we're one of the countries which started earliest with the preventive measures. We were, among the probably 2 or 3 countries who were the first to, have a quarantine and lock down cities and even lock down certain regions. Austria was, of course, in a geographically difficult situation because we're very close to Italy. And we have another situation which makes it quite difficult. We have a lot of tourism. So there's a lot of travel. And the hot area in Austria is actually Tyrol. Tyrol, as you know, obviously is a place where we have a lot of skiing going on. And in this region, where you see the hot map very, very high, this is where we have the shutdowns of specific regions where these people are actually completely locked in their towns. But we do see cases in all of Austria. We see them in Vienna, but not as much, of course, as in Tyrol. We have them in Upper Austria. So there's a pretty, continuous spread of the virus throughout Austria. And coming back to the situation that we had in Tyrol, in the Arlberg, which is one of the most famous ski resorts in Austria, the interesting thing was that one of the major problems there was that it spread from actually one place mostly. That was a disco or a bar, which it was in a skiing resort in Ischgl. And from there, a barkeeper was spreading the virus, and we can even see traces of that virus all the way up to Iceland, Norway, Sweden. So this is how the virus actually spread to certain regions. I guess this is something that you will probably see, in every epidemic, that you have certain traces where the virus is moving based on where a lot of people come together. And in this disco in Tyrol, people are very, very close. It's very famous to go après ski, as we say, after skiing, and that's how they were infected. Luckily, like I said, these areas were shut down completely, and luckily we started the preventive measures very, very early. We do see a lot of cases though, but at least when we look at the news, we have optimism that we might be able to have a trajectory which is not as steep as in other countries. But again, we have to watch out for that. And in reality, we have a really high, I would say, discipline among the population, the people as well. But one problem, and that is something that I see among our colleagues, is that doctors are very strongly affected. This is a study which is actually not a study, it's more statistical analysis, which was performed by Colliquio in Germany, which has a very similar situation also. And if you look at the numbers here, we see that a significant part of healthcare institutions, private clinics, but government-based clinics, so outpatient institutions and hospitals are already involved, and that we have a lot of cases among the community of doctors and nurses as well. In my hospital, in the Medical University of Vienna, we also have cases. Yes, we've seen them. And this does present a difficulty. Basically, what we try to do is we try to form teams A and B so that we can be sure that there's a replacement of cases. So I think that's just very, very important. So, of course, this is very, very important at the moment to also perform statistics, not only based on, I would think, science, but also perform surveys as the one that was just done by Colliquio, who we're very happy to partner together with. finally, I do want to come to an issue and then kind of move on to the next topic, which is going to be basically ultrasound, and that is just a video that it's been circulating in the U.S. and also on social media, and maybe after that I'll have you comment on your thoughts on this.
All the patients in this room, all the feet that you see, they all have COVID. The frustrating thing, all of the doctors, it's hard for us to get tested even if we want to, even if we have symptoms. We're exposed over and over again. We don't have the protective equipment that we should have. So we were seeing a lot of patients who probably had COVID, but we didn't realize. 10 residents and also many of our nurses and a few of the attending physicians got sick. The anxiety of this situation is really overwhelming.
So this is of course from the US, and I would like to maybe again ask Balil what your thoughts on this, especially with respect to one problem which I see a major problem is that we still have patients coming in for other diseases, and it's sometimes very difficult to say whether or not someone of these patients has the virus. And what about a patient with dyspnea, for example? Would we put everyone through a test? Should we perform a CT in every patient? What is your take on this? Wir hören ihn jetzt nicht. Ich kriege kein Signal von ihm. Okay, I'm afraid we can't hear you at the moment. Maybe you muted your microphone.
Can you hear me now?
Yes, now works.
Okay, so for most patients who are coming in who don't have a fever and don't have specific symptoms that would be suspected for COVID, if they're short of breath and they have pulmonary edema on a chest x-ray, their BNP is elevated, we know they have a history of heart failure, their legs are swollen, those are people that we're considering low risk for COVID-19. And if we have an alternate diagnosis that explains their sickness, those people do not get tested. Only patients who have no other explanation, and we think this is a infectious syndrome, and that can be from a lobar pneumonia all the way to flu or COVID-19, all of those people get tested. If you're getting admitted to the hospital for a respiratory illness, regardless of whether we think it's an infection or not, that will get you tested as well. The problem now we're running into is the sensitivity and specificity of these tests. And so a lot of patients are actually getting double tested. So they'll get a first test done, and if we feel that their risk is really high, we'll retest them at 48 hours. And only if they have 2 negative tests do we take them out of precautions. If you have 1 negative test, but we also have an explanation as to saying that you have strep pneumo antigen positive on your urine, you're getting better with treating your pneumonia, and your COVID-19 test is negative, those are people we're not retesting.
I think that's certainly a good approach to the problem. I just want to mention that we have now more than 6,000 people in this webinar, so we are reaching a lot of people, and we do hope that all of you out there are getting what you're expecting from us. We get hundreds of questions. I know it will be very difficult to answer all of them. Maybe at this point, just because one of the questions keeps on popping up is, what about the problem of ventilators, and do you really use non-invasive ventilation as well, or is that something that you would not perform in these patients? Maybe I'll ask Jean-Jacques, because or maybe both of you. Maybe you can give me your take, and then I'll move it to Jean-Jacques.
So for the 2 oxygen delivery devices that are also aerosol generating are both high flow nasal cannula. It's either called Vapotherm or Airvo or high flow from a different company, and then non-invasive ventilation, BiPAP and CPAP. And so we as a hospital have made a policy that we only get you low flow oxygen up to 6 liters, and if 6 liters is not enough to get you oxygenating better, we'll consider high flow very carefully. 30 liters max flow. We'll put a mask on your face that usually catches all the droplets that are coming out. Absolutely not using non-invasive ventilation. And this is becoming a problem now with patients who are DNR, who we're not going to put on a ventilator.
What's your take?
Okay, you know, at the beginning, we did exactly the same. In those patients who had a non-critical COVID pneumonia, they were hospitalized and without short of breath. And suddenly, they become short of breath and increase their respiratory rate. So at the beginning, we are trying non-invasive ventilation, high-flow nasal cannula. But you know, in 99% of these patients, these non-invasive modes fail and the patient are intubated. So right now, knowing that the patient is COVID and worsening with short of breath and high respiratory rate, we intubate the patient because we know that 90% of these patients will be intubated. So delaying the time of intubation is risky.
Okay. Well, thanks for your comment here. One other question we're getting from Maria is, she says, Dear Professor, I find it really crucial to make a PCR to each single patient who is going to be hospitalized because we can easily miss the oligosymptomatic. Coming back to the question we just discussed previously, maybe Jean-Jacques, what is your thoughts here?
We had several cases at the beginning where the symptoms had nothing to do with flu or with COVID pneumonia. And suddenly the patients worsened, had a respiratory failure, had to be intubated, and then they were tested and they were positive. So right now we are testing all patients entering the hospital.
Yeah, this is pretty much what we do at the Medical University as well. We test every patient that comes in. We'll see. But let's move on now, because the third big topic that we're discussing here now is the question of should we use point-of-care ultrasound? And maybe, Jean-Jacques, can I have you present your experience here, because you've been instrumental in implementing this on intensive care units in the medical community. So you are probably one of the leading experts in this field. Can you maybe just present us your experience with teaching and also using this in patients such as COVID-19?
Okay, just to begin with, you know, in this patient, we need to avoid intra-hospital contamination. So the aim is to avoid to go to CT scans. Maybe we should avoid bedside chest radiography, because each time the radiologist technician is entering the ICU with the big machine, then it's difficult to decontaminate, and there is a risk of contamination. So ultrasound offers the possibility of giving a very good view of the lung status according to time without transporting the patient or some foreigners entering the ICU to make a special examination like a chest X-ray. So I think it is the probably the method of choice. But most of the time we are using bulky ultrasound device because we want to do transesophageal cardiac echography, we want to do transthoracic cardiac echography, abdominal echography, and lung ultrasound. So most of the time we are using bulky machines, and it's very difficult to decontaminate these machines. So we have taken the option to use the pocket-sized machine that are very easy to decontaminate to avoid this risk of intra-ICU contaminations. This is just a small introduction to explain why we should use these pocket-sized ultrasound devices.
Okay, so that's of course a very important part. we need to take care that we do not infect or would not carry viruses to other places of the hospital. And a point of care ultrasound is small. It's relatively easy to take with you, and it's probably easier to disinfect as well. But what about just in general the role of ultrasound? I'll just maybe start your presentation, and maybe you can just comment on.
Okay, I will drive it from my computer.
Okay.
It's easier. Okay. Let me just connect.
Maybe while you're working on the slides to get them in, I have a number of questions coming in. Maybe we can ask them. One thing that keeps on popping up is, and Edlira is asking, is there evidence of lung damage in mild cases who don't need hospitalization? How long does the cough last once the other symptoms have resolved in a mild case? Does anybody have any experience here? Does anybody want to comment on this?
Yeah, I can do it.
Okay, please.
Okay, it depends of the clinical signs. Now, if the patient is not short of breath, if is with a fatigue, flu syndrome, headache, cough, without increase in respiratory rate and short of breath, it can have a pneumonia because some ultrasound examination of chest X-rays has shown that. Yes. No. Do you hear me?
Yes, I can hear you.
Okay. So I would say that clinical symptoms are determinant. If the respiratory rate is suddenly increasing, short of breath, dyspnea, then it means that probably the patient is going to be intubated. So then you need a monitoring tool of lung status. Do you want me to make a short presentation of
yes, please.
what we
please
can
do
see
so.
on lung
Please do so.
Yeah, okay, so this is the Lapitié-Salpêtrière Hospital. It's a very large hospital. We have 1,600 beds, and this is one of the ICU. We have 6 beds on one side and 6 beds on the other side, isolated 1-bed rooms. Okay, so you are going to take the probe of your ultrasound machine and put it on an intercostal space, because the intercostal space is the acoustic window to see the lung. Normally, if the aeration is normal, you do not see anything. So this is the subcutaneous tissue. Your probe is here. The bright line is the pleural line with a lung sliding. Both sheets of the pleural layer are moving on each other. And then you have an artifactual repetition of horizontal line called E-lines, okay? This is a normal aeration. So if somewhere on the chest wall you see that, it means that it is normal. It's a very important information. Sometimes in dependent part of the lung, you may have 1, 2 vertical lines. This is not abnormal. So the normal aeration is defined as the presence of E-lines, horizontal lines, or less than 3 vertical B-lines. Okay, now we move to interstitial syndrome. The excess of inflammation, lung water, involves exclusively the interstitial space. And this can be the case in hemodynamic edema, fibrosis, and early stage, non-critical stage of SARS-CoV-2 viral pneumonia. It has been described, some very early ultrasound examination demonstrate these ultrasound pattern characteristic of interstitial syndrome. So the abnormal interface between gas and tissue produce vertical artifact called B-lines. This is the characteristic of the vertical lines. They are arising from the pleural line, well-defined, reaching the edge of the screen, moving with pleural line, and you do not see anymore horizontal E-lines. This is an example of what you can see. This is an hemodynamic pulmonary edema, okay? The interlobular septa are thickened, and the interface between this excess in tissue in the interlobular septa and the gas create this regularly spaced vertical B-line. You cannot miss it. And this is never observed in SARS-CoV-2 pneumonia because it is not an hemodynamic syndrome. Okay, sometimes the multiple B-lines are irregularly spaced, and there is an impaired lung sliding, and this is seen in non-critical SARS-CoV-2 pneumonia. Sometimes the B-lines are issued from juxtapleural consolidation. This is characteristic of non-critical SARS-CoV-2 pneumonia. Now, I take an example. If you have an ultrasound machine and a patient comes with clinical signs corresponding to non-critical SARS-CoV-2 pneumonia, if you perform lung ultrasound, you will detect these small juxtapleural consolidation with B-line issued from this consolidation. This is typical. You will see that in emergency wards, in infectious department. The next step is to have, very much larger subpleural consolidation. And they are also seen in non-critical SARS-CoV-2 pneumonia. They are the reflect of confluent bronchopneumonia. It's a more severe stage than the previous one. But the aeration is still relatively preserved in the lung. Sometimes you have localized areas of ground glass areas, and they give, this is rib, and then you can see coalescent B-lines issued from the pleural line. But if you move your probe along the intercostal space, then they will disappear. They are localized, and this is also typical of non-critical SARS-CoV-2 pneumonia. Now, if the patient has acute respiratory failure, and if he has an hemodynamic pulmonary edema, as you can see, the ground glass areas on the CT scan are widespread. And then you will get everywhere on each intercostal space coalescent B-line issued from the pleural line. This is typical of hemodynamic pulmonary edema. You do not see that in COVID patients. What you are seeing is something like in ARDS. This is an ARDS. It is not COVID pneumonia. Then you have ground glass areas, and the coalition B-line are issued from subpleural consolidation. In other words, you have a foci of bronchopneumonia, and you have pulmonary edema, high permeability type pulmonary edema. What is typical, absolutely typical of SARS-CoV-2 is this CT aspect. It's a ground glass area. It's not consolidations. That is widespread through the lung parenchyma. And then when you put the probe on the chest wall, you have this diffuse B2 line, coalescent B line, all over the chest wall. All the patients we had, more than 30, correspond to this pattern. In ARDS, you have a predominance of consolidation. In a critical SARS-CoV-2 pneumonia, you have a predominance of B lines. It means that there is some gas persisting in the lung, but coexisting with pulmonary edema, which is protein rich. It's a high permeability type pulmonary edema. In fact, lung consolidations, like you can see here, are not very frequent in SARS-CoV-2 patients. When they are admitted to the ICU, we don't see consolidation, contrasting with the other cause of RDS. In the other cause of RDS, you have massive consolidations of lower lobes, like you can see on this ultrasound video with a pleural effusion. But in SARS, COVID, the pleural effusion is rare and the consolidation occurs are delayed. They occurs 3, 4, 5 days after the admission, because most of the time there is a bacterial infection. Then you can see the consolidations. And the consolidations are with hyperechoic punctiform image, reinforcing at inspiration. It's attesting the static air bronchogram. The bronchial tree is still filled with air and the lung parenchyma is consolidated. Sometimes you see the secretion moving inside the consolidation in the bronchial tree. This is typical of pneumonia, not typical of SARS pneumonia. It is typical of superinfection of COVID patients with common gram-negative bacteria. What is interesting is that in the consolidation, you have a persisting blood flow. If you put the Doppler here, your probe is here, you put the Doppler, you see that the pulmonary blood flow is persisting, explaining that the patient is deeply hypoxemic. In fact, you evidence the pulmonary shunt. Okay, so pleural effusion, as I told you, is relatively rare in non-critical and critically ill patients with SARS-CoV-2. We do not see pleural effusion a lot of time. To my knowledge, for the first 30 patients, no one had to be drained. There was virtually no pleural effusion. Pneumothorax, we don't know exactly because we didn't see yet any pneumothorax. You see that lung ultrasound is very accurate to detect lung ultrasound. In fact, there is a abolition of lung sliding. And if you use a monodimensional echo, then you will have these linear lines. You know, partial pneumothorax can be easily detected by lung ultrasound. Look, if you have an anterior pneumothorax, then the junction between the lung parenchyma and the gas is moving, and you can see the lung point here moving. So you can very easily detect anterior pneumothorax using lung ultrasound. Okay. So I just want to show you the difference between a pocket-sized ultrasound device and a bulky ultrasound device. These video were taken in 6 years ago in our ICU because we used the V-scan. It was the first version. There was a single probe. There was no Doppler. And, you know, this is the ultrasound machine, okay? And there's something wrong in this, okay? To see how it is easy to handle and then to clean, of course. This is you can see the B line in this patient. It was not now, 6 years ago. This patient had a hemodynamic pulmonary edema. So we discovered at that time the advantages of pocket-sized ultrasound machine. So what we have decided in our 2 ICUs is to separate the beds. Beds 1 to 6 will be handled exclusively with the pocket-sized ultrasound machine. No chest X-ray, no transportation to the CT scan, and we will perform lung ultrasound score each day to monitor the lung status. And if we see that the lung is reaerating, then we'll perform immediately a spontaneous breathing trial to try to extubate as early as possible the patient and have some more room for the patient waiting for admission in the ICU. On the other beds, 7 to 12, we'll use a very bulky ultrasound machine. And of course, we cannot use as often this ultrasound device to monitor the lung status. So in this part of the ICU, we have permitted the practice of bedside chest radiography. And then we'll compare the duration of mechanical ventilation. In this part of the ICU, we'll monitor each day the lung ultrasound score. Here, we'll monitor using bedside chest radiography according to the physician decision, ultrasound according to the difficulty to transport and decontaminate this machine. Here, all the catheter insertion and control of the adequate position will be done with this pocket-sized ultrasound device. In other words, there will be no transportation, virtually no transportation outside the ICU or no bedside chest radiography. And then we'll compare this, the time of mechanical ventilation, the number of contamination, the time required to decontaminate this machine and this machine. And this study is going on. It is embedded into the clinical care, here facilitating the care for the physicians, avoiding probably contamination in the ICU, and it is supported by the clinical research of Assistance Publique Hôpitaux de Paris, which is the big organism running all the university hospital in Paris. Thank you.
Jean-Jacques, it's really, really amazing what you're doing in this very, very critical phase to provide more information on how we can manage these patients. And I can only reiterate, lung ultrasound is a very, very important modality. And if we can maybe tell what the prognosis of the patients is and how we should manage them based on the lung picture that we saw just previously, I think that would be a tremendous advantage. Obviously, CT is something we cannot implement on a large scale in these patients. For all of you who are interested to learn ultrasound, it's something that is not so difficult to learn. Yes, you'll need some experience, but it's something that you can learn. And what we from One to Sonography did, we filmed a complete lecture, a course on, of course, point of care ultrasound. And there will also include the topic of lung ultrasound. So if you are, after the lecture, you can go to the webpage that I will present to you at the end of the presentation, and you will be able to download or to look at your lecture. It's yours. You can view it as often as you want to, and maybe kickstart your career in ultrasound, lung ultrasound, if you haven't done it so far. So I think it's a very important initiative that is supported also by General Electric. I must honestly say they've been helping us tremendously in, of course, moving education forward to you. I guess they understand that it's very important that at this stage we need to provide information, especially since many other channels are not possible at the moment based on the fact that all conferences and meetings are now banned. So this is a very important factor that I just want to mention again. But now let me just move on, and I do want to have maybe also Martin's presentations on ultrasound, because this is also something that is very important, because as I mentioned previously, not all patients have COVID, but patients with COVID can also have other problems. So here are some case examples to demonstrate the role of point-of-care ultrasound.
So as you mentioned, that's absolutely right, that on the one hand, we do not forget that many patients will be infected with COVID and they do not have flu symptoms at the beginning. And on the other hand, patients with dyspnea, for example, also can have different diseases. Not everyone has COVID. And this is a case example where we have to look really closely what the problem is. And if you go to the next slide, we can meet a patient. His name is Reinhard. Next slide, please. Tommy? Can you go? Yeah, thank you very much. So we are now seeing Reinhard. Reinhard presents with dyspnea, and he had a myocardial infarction 2 months ago. And he tells me, I think there is water inside of me. And here you see 2 loops. On the left-hand side, you see the IVC, that's the echo loose structure in the center of the image. It seems dilated, and with respiration, it's not collapsing entirely. Above the IVC, you see the liver. And on the right-hand side, you see the liver again and the liver veins. They also seem to be a bit dilated. And if you move to the next slide, we see the left-hand side, the liver again, and we see another echolucent structure, 2 echolucent areas. One is pleural effusion, that's on the left side, and on the right side, if you do look really closely, we also see ascites. And in the loop on the right side, we see the liver and the kidney again, and in this area where the arrow pointed now, we see again an echolucent area which also points towards ascites. And if we look around a little bit more and tilt and turn the transducer, so go to the next slide, please. We see more areas in the abdomen and in the lungs where there is free fluid present. And now the question is, next slide, please. What is the problem of the patient? And with point-of-care ultrasound, we of course also can scan the heart. And if we look at the next 2 loops, we see on the left-hand side a short axis view of the heart, and you see in the center of the image the left heart. It's shaped like a D, so a D-shaped left ventricle, and the right ventricle seems rather big. So that's a sign for elevated right heart pressure. And if we look at the right side in the image, it's pointing already towards at the right ventricle and the right atrium, and the right ventricle and the right atrium, they're severely dilated. And what you also can see in the center here is an ICD. So this echo dense structure, exactly, so that's the ICD. And if we go to the next loop, and we implement color Doppler, so those are all images from also a handheld device, the Vscan Extend. What we have seen in the previous presentation was the Vscan without color Doppler imaging. Here we can add color Doppler, and we see a massive TR. So what is the problem of this patient overall? This patient had a myocardial infarction, and he had an LAD and a right coronary artery problem. Go to the next slide, thank you. And he has a pleural effusion and a severe TR, probably ICD related, and he has ascites and a reduced right ventricular function. So this patient had dyspnea, but of course this was not a COVID patient, at least not at this time. And if we look at the next patient, her name is Greta.
The next patient, I just want to maybe pitch a question to you.
Yeah, sorry.
Yeah, I just want to pitch a question to you because we have one that might also work quite well with the presentation. And the question from Jaime is, can ultrasound be used as a triage tool? I guess, of course, in many different situations, but also in the COVID situation. What is your take here?
So what you can immediately do is, for example, as Dr. Ruby mentioned, that you rule out pneumonia and rule out the pleural effusion. So a patient can present with dyspnea and he can have other kind of problems, not only COVID-19. And if the patient doesn't seem too good and you see a pleural effusion and a corresponding consolidation, this patient might have a bacterial pneumonia. So you have to treat the pneumonia and you won't think probably initially about the COVID-19 infection. And what Dr. Ruby also mentioned previously is you can scan the anterior parts of the lung and see distribution of B lines and also the features of the pleural line. So if you see some or many small consolidations and many irregular distributed B lines, and you have a dyspneic patient with high fever, that is a patient who is more likely to be intubated in a later stage. Maybe also Dr. Ruby wants to comment on this one.
Yes, but let's say if you have a patient, a non-critical patient, without signs of respiratory failure, if you perform a lung ultrasound, you can see there's a subpleural consolidation from which are issued coalescent or spaced B lines. It's an early stage. But many of these patients will recover without deteriorating. And when they deteriorate, you have an invasion of the ultrasound pattern by coalescent B line. It's exactly like a pulmonary edema, hemodynamic pulmonary edema, but it is not. It is a high permeability type pulmonary edema related to the virus injury on the lung. And what is characteristic is that at this stage, the coalescent B line is sometimes issued for multiple juxtapleural consolidation. But then the B lines invade the entire lung. This is a characteristic of all intubated patients due to COVID-19. This is very strange for me because I have seen RDS patients all my life. I've never seen such a uniform presentation in terms of lung ultrasound.
This is highly interesting. I think very, very valuable information. Maybe just to explain how we will proceed. We now have 9,500 people in the webinar. So I have an impression the longer we go, more people come. So what I thought is we would maybe extend a little bit and answer some of the questions which are coming in, because I think this is something that is really on the mind of many people. And before we go back to maybe Martin's question, I do want to answer, post the question to you, maybe Dr. Balel. What is the role of lung ultrasound in the patient who does not have severe critical symptoms with COVID infection? Does it play a role there? Could we actually use this technology to maybe diagnose or maybe even find those patients who have a little bit of a more progressive disease of COVID-19 than others?
So I don't think, and I think the other two on the group would agree with me as well, that I don't think lung ultrasound in itself can, as a sole measure, diagnose COVID-19 infections. I'm primarily using it in my practice, specifically on patients that I can't do CTs or chest x-rays on. I'm using the lung ultrasound as the only measure I can use to image the lungs. And it's more so I'm trying to gauge the amount of lung injury or the amount of lung involvement. The second thing you can use it for, which I'm also using it for, is to track these patients when they're in the ICU. So if someone has had a CT done already, they got admitted, they're positive for COVID, they're intubated, and we're restricting, echocardiographers to go in, restricting radiographers to go in. We're not getting any of the diagnostic imaging we usually use in an ICU to get the answers we need. Also, and to attest to what Dr. Ruby said, these bulky conventional standalone machines, they're not easy to get in and out of a room or even to clean and decontaminate well. So I think it comes down to your obviously clinical suspicion, the clinical history and the symptoms and the lab findings the patient has, and then as an adjunct to confirm a lot of the suspicions you have or to come up with newer ideas, using ultrasound is the way to go in taking care of these patients.
Yeah, I think a great point that you're making here, that obviously you cannot make the diagnosis of COVID-19 and that there are certain clinical situations which look very similar. But again, also interesting to hear that there are some very specific findings that we can use as well. Let's now proceed with the presentation by Martin and then come back to you and discuss lung ultrasound a little bit more in detail after the presentation from Martin. Martin, I'll have your presentation ready.
Yeah, I just want to say that I completely agree with Dr. Balil. So never solely use imaging for a diagnosis. Always look at your patient. Is the patient dyspneic? Does the patient has high fever? And also look at the O2 saturation. If it's really low and does it deteriorate when the patient is, for example, just walking, that might be a more critical patient. So then maybe you should implement imaging, and that could be, of course, lung ultrasound. But yes, I'm happy to continue with the presentation. So let's have a look at another patient. Her name is Greta. And Greta presents 9 a.m. on Sunday, and she's 85 years old, and she complains of dyspnea. And therefore, quite some time, she doesn't remember when the dyspnea actually started. And for now, she has never seen a doctor in her entire life, and she doesn't take any kind of medication. But if we perform point-of-care ultrasound, we can see some interesting findings. So if you go to the next slide, on the left-hand side, we see the liver, so this organ in the center of the image. So go back one slide, please. So exactly on the left-hand side, we see the liver, and we see somewhat dilated liver veins, and also we see perfusion. It's not too big, but it's definitely present. Maybe you can just show with the mouse where the perfusion is located, exactly here at the left side of the image. And if you look at the right side, that's an image, a subcostal image of the heart, and we see here where the marker is pointing now a pleural effusion again, and we see also a little bit dilated IVC, and we get a glimpse of the heart. And if you go to the next slide, it is a more clear presentation of the pleural effusion. Again, all these echo-free areas, exactly here, this is pleural effusion. And now we have to go and see why this patient has a pleural effusion and dilated liver veins. And if we see the next slide, we see a peristernal long axis of the heart. So peristernal image on the left side without color Doppler, on the right side with color Doppler. And in the center of the image, we see the aortic valve, and it's quite bright and quite white. So this is massively calcified. And if we do look at left ventricular function, it seems pretty poor. Also look at the mitral valve, how it is opening, just a little bit of opening of the mitral valve. So the left ventricle exactly here pointed out with the marker, and here the mitral valve. And if we go to the next image, we see an apical 4 and 5 chamber view. And what we can appreciate here is a little bit of pericardial effusion, even around the left ventricle on the left side of the image. exactly here. And we see a severely reduced left ventricular function. And on the right side of the image, again, we see the reason for all of this. It's this massively calcified aortic valve. And so what is the diagnosis? What did we see overall in this patient? We saw, if you go to the next slide, an aortic valve, and this aortic valve was severely calcified. So we do have the suspicion of aortic stenosis, of course. And click again, please. And left ventricular function is severely reduced. Exactly. Also, right ventricular function, did take a brief look at it, and it seems to be still rather normal. So again, another patient presenting with dyspnea, having a different disease, not COVID-19, but severe aortic stenosis. And the last patient I want to present to you is a patient, an immunosuppressed patient, a patient who received a new lung just 2 months ago. And because this patient was in contact with staff members who were tested eventually positive, after having COVID-19 symptoms, they were coughing, they had dyspnea, and this PCR was performed 2 days after he had contact with the staff, and it was negative. We received the patient at the rehabilitation center, and of course we were concerned and questioning ourselves, what can we do and how to deal with this patient? This was a patient with lung transplant or receiving a lung transplant, and we are having some patients who are immunosuppressed because they received a lung transplant. So of course we isolated the patient, and we made sure that the patient is not exposed to us as well. So we always tried to keep as much distance as possible, and we were wearing, of course, masks. And then a few days later, the patient started coughing. So again, what did we do? We decided, because of the high risk of the patient, to test the patient again. But that was not all what the patient was experiencing. So if you go to the next slide. Also, before the patient came to us, the patient had a perforation of the small intestines. And now, when we took the test, he was mentioning that he feels abdominal pain. And when you touch the abdomen was actually hard. So we performed point-of-care ultrasound. And in the next image, we see right upper quadrant view, we see the kidney, the right kidney in the center of the image. We see a bit of the liver. And in the Morrison's pouch, so in between the right kidney and the liver, we do not see free fluid at first glance. And when we moved the probe to the point of pain of the patient, where the patient felt that it really hurts, we saw, can you go to the next slide? Exactly this. We see in the center of the image, this is a dilated intestines, and we see this pendulum peristalsis. And because of the history of the patient, because we did see this on the point-of-care scan, we sent him back to the hospital he got the lung from, and of course there was performed a CT scan. And how did this patient, or did this story continue? The CT scan was positive for a perforation of small intestines, and he was operated immediately. Well knowing that this patient had contact with COVID-19, so of course the hospital where he was operated, they took measures that they also treated him like a COVID-positive patient. After all, he was COVID-19 negative at the second test as well.
A wonderful example, again, how we can use ultrasound so ubiquitously in different settings and make so many important diagnoses. So thanks a lot, Martin. Again, for all of you who are interested to learn point-of-care ultrasound, we have free lectures for you, a mini course, which are going to be 25 minutes each. After the presentation, all you need to do is go to the webpage that I will display at the end, and then you can actually download or actually look at the presentation. Good. So yes, point-of-care ultrasound is very important, but I don't want to move back again to lung ultrasound, and maybe let's go back to Texas. Let's see how it is done there. I don't hear you at the moment.
If you want to get my presentation up.
Yes, I'll get your presentation. You just need to tell me when to advance, but I have your presentation with me in a second.
We can probably start off at the CT and chest X-ray slide. I think it's number 5. So the reason I had this slide up is there are some very good studies done, some out of Italy, some out of China, demonstrating CT scan and chest X-ray findings on patients. And I think Dr. Ruby and Martin both mentioned ground glass opacities with or without consolidation is your alert sign where you get concerned about COVID-19. Some of these CTs have bilateral. There's some that they've seen unilateral ground glass opacities with. And then the X-ray findings have very subtle areas of opacities that you can see on their chest X-rays. There are other findings that we can use as well, including lab findings. So leukopenia and lymphopenia are hot ones. Other than that, elevation of liver enzymes and the D-dimer, those are things that kind of help you make a presumptive diagnosis and then confirm it with testing. But lung ultrasound, we've been talking about it for quite a while now. There's some specific findings that are related to COVID-19. Some of them Dr. Ruby has shared already, and I'll continue on that. If we could go to the next slide, please. So in the ICU, you will have patients that are mostly supine, and you have to define out lung zones. So this is from Dr. Lichtenstein, where he's defined out 3 zones, and then an upper and a lower. So kind of 6 zones on one side, so 12 zones in total to the lung, where you would ultrasound a patient. One important zone to remember is the PLAP, the posterior lateral alveolar space, or pleural space, that's at zone 3 in the lower. So that's one of the spaces that we absolutely have to ultrasound in addition to everything else. We could go to the next slide. So there's some artifacts on lung ultrasound that we use, and these were mentioned before. So the image on the left is showing us A lines. Those are repetitive lines that you can see, and those are basically reflections of the pleural space, and it's a artifact that we see on the ultrasound image. And on the second, on the right side, you can see some very thin B lines. One of the other things that we're also paying a lot more attention to, specifically related to the flu pandemic, but also related to COVID-19, is looking at the pleural line. So on the right side, you can see a very irregular pleural line. It's not very thickened, but every time it moves, it's not one straight line. It's got some irregularities to it, and it's different from the image on the left, where you've got a thin, very regular pleural line. When you have patients that are sitting up, for example, in the emergency room or in the ward, I would recommend that you perform lung ultrasound in the posterior chest as well, and in kind of a lawnmower fashion, where you pick one rib space and then you scan that entire rib space all the way laterally, and then you go up or down depending on where you start. These B lines are very there's some very specific characteristics to it, so we could go to the next slide. But the things that we're looking for are the pleural line, the characteristic of the B lines, and then the quantity of the B lines we're seeing. And so on this slide, it's a good demonstration of pleural irregularities. So the one mentioned as few B lines and the one is mentioned as many B lines. Both of those have irregularities of the pleural line that you can see very well. The image in the middle, you can see a thickened pleura. So both of these have been reported, both pleural irregularities and pleural thickening. Both have been reported in COVID-19 patients on lung ultrasound. The thing I want to mention out of this slide is when you look at the slide that shows many B lines, you're seeing confluent B lines in this. Confluent B lines which are associated with pleural thickening or pleural irregularities and their distribution, that can tell you a lot about whether this patient is likely to have COVID-19 or not. Can we go to the next slide, please? So the clinical correlation is very important for figuring out what we're seeing on lung ultrasound, and its distribution is also carries a lot of information for us. So first of all, obviously, when we clinically correlate, you'll start off with symptoms. The right patient, someone who's having fever, someone with shortness of breath or a cough, who's may or may not have had contact with a patient with COVID-19. And I kind of came up with this chart when I teach ultrasound to my residents or my fellows, I use this chart as well, that you've got to focus on the distribution of lung ultrasound B-line findings. So if you have bilateral B-lines, and if they're diffuse, you start thinking about processes like pulmonary edema and ARDS. If you have bilateral B-lines, but they're only in certain spots on the lungs, not throughout the lung, you would start thinking about multifocal infections. Interstitial lung disease can also give you B-lines and a patchy distribution that's bilateral, so that's something else to think about. And on the rare occasion, a viral infection such as COVID-19 or the flu can also give you those findings. In the unilateral findings, when they're diffuse, you either start thinking about asymmetric pulmonary edema that's usually non-cardiogenic, or a large lobar infection or a large infection on one side of the lung. Patchy infiltrates that are, or patchy B-lines that are unilateral would mostly point you towards focal infection, and Dr. Ruby shared some of those slides earlier. We can go on to the next slide, please. So viral pneumonia. Viral pneumonia is a hot topic in lung ultrasound right now. And the three things that I have learned to look for in these patients, obviously looking for confluent B-lines, looking for a patchy distribution, whether that's unilateral or bilateral, and also looking for pleural irregularities. I also combine lung ultrasound with cardiac ultrasound because the lung and the heart kind of work together. And if you can correlate what you find on the lungs with the heart, so if you have a low EF and you have bilateral B-lines that are diffuse, it kind of gives you a diagnosis there already. Could this patient also have COVID-19? Absolutely could. But is it the primary thing that I'm going to be treating right now? Probably not. We can go on to the next slide again. So this is something that I've put in there as a finding that would deter you from saying this is absolutely SARS-CoV. So air bronchograms are mostly classified as either static or dynamic, and they're seen in a consolidative process. If you have lung consolidation, your lung will become hepatized, and very well seen on the image on the right, that hepatization of the lung. It almost looks like the ecotexture of a liver. Within that, if you have trapped air, that would show you static air bronchograms, and static air bronchograms are actually shown better on the image on the left. The C is marking the consolidations, and the D is marking that diaphragm that you can see coming in and out. The characteristic of dynamic air bronchograms is being able to see air move in and out of the lung. And on that image on the right, you can very well see the air moving in and out with respirations. It argues this being atelectasis because atelectasis technically should not have any air movement. There are other studies that have been performed using M mode on a consolidated lung or using Doppler to see the movement of air if it's not well visualized on the ultrasound. So those are two additional things that we can sort of incorporate to strengthen our suspicion of this being a lobar pneumonia or not pneumonia. This is not something you should see with SARS-CoV. This is something that is lobar pneumonia or atelectasis. Effusions also, there's a small effusion that you can see on the image on the right, which is labeled as an E in white. Effusions are also uncommon, almost very, very rare in viral infections. There are 2 case reports that I've read with very small effusions in patients who were COVID positive, and I'm suspecting those are probably parapneumonic effusions from a superinfection with bacterial pneumonia. We can go on to the next slide. The other finding that you will see with pneumonia or bacterial pneumonia on ultrasound is a shred or a fractal sign. And this is where a consolidated lung is having an interface with a normal lung. And so that same interface of air, of fluid and air, you're seeing deeper down in the lung. So both of these are actually obtained by a portable device, a vScan Extend. And you can see those shred signs on both of those. Both have very small pleural effusions. I think the one on the left would have a slightly larger pleural effusion than the right-hand side. And then the next slide would be for pleural effusions. Again, another thing that if you see a large pleural effusion, so a normal lung will look like the image on the left, where you can see the diaphragm and you can see the lung coming in and out of the diaphragm, almost like a curtain. The O is the organ that's below the diaphragm that can either be the liver or the spleen, and the D is labeled as the diaphragm. On the image on the right, you can see a large pleural effusion. You can see the tip of the lung that has resorptive atelectasis on it, and then you can see the diaphragm and the organ on the other side. If you're seeing a large pleural effusion in someone who has a fever and a cough, this is not primarily from COVID infection. This is probably from something else. I would recommend doing a heart ultrasound to make sure that they don't have congestive heart failure or don't have a history of malignancy that's giving them a large effusion on this side. And then on the next slide, you'll see complicated effusions, so effusions that have septations and debris within them. These are absolutely not related to COVID-19 infection. In fact, the image on the left was from a patient that had a empyema from a bacterial process and required a tube thoracostomy with drainage. Image on the right, labeled as S, you can see septations within the effusion. And again, something that carries you away from a primary diagnosis of a COVID-19 infection. There's some small effusions, again, being reported with a COVID infection, but nothing as large as these ones or as complicated as these ones that could be there. If they're present with COVID-19, these are probably related to a superinfection with a bacterial pneumonia or a bacterial empyema that's giving you these findings on lung ultrasound. And then the last slide that I wanted to talk about was a blue protocol. So Dr. Lichtenstein, big name in lung ultrasound in the US, sort of coined this together and kind of helped you differentiate what kind of profile your patient has and lead you to a diagnosis. The A profile is where you have normal lungs, you don't have any B lines, there's no interstitial filling process, and in the right patient that could be an indication for pulmonary embolism. They recommend doing DVT scans using ultrasound to get more additional information that would help you make that diagnosis. A B profile is mostly B lines when they're bilateral, as we talked about early. That could be a sign of pulmonary edema. Unilateral, and you could think of a pneumonia. And then the C profile is a consolidation profile where you're seeing those findings in the PLAP, or the posterior lateral alveolar and pleural space, where you're seeing consolidations, and that would give you a reason to believe that this is pneumonia. So this is something that I've kind of automated in my mind, and I think the ultrasound device that I use actually helps you make a lung protocol out of it. It's a software that they've installed onto the device, and it kind of walks you through this entire protocol as well, which would be helpful to use for novice ultrasonographers or people who are just getting started on lung ultrasound.
I think that all these tools are very much needed. First of all, I think to all of you who have maybe not so familiar with lung ultrasound or ultrasound in general, it's not such a difficult technique to learn. Yes, you need some practice, but you can all learn it. And like I mentioned, we'll have a tutorial, and of course what was just presented was a fantastic overview. The webinar will be downloaded or uploaded on the internet. You can view it again, so this information is there to stay. What I would propose, now that we've actually come to almost 2 hours of having this webinar, is just maybe a very brief session where we do answer some of the questions that are coming in. We have, I can almost not believe the number, 11,000 unique viewers in this webinar, and I think that we should use this opportunity to answer some of these burning questions out there. Many of them are actually on the topic of lung ultrasound, but many of them are general questions. One of the questions that came up several times was, what about the risk of getting lung fibrosis? Is that a problem, that some patients might get lung fibrosis even if they do not have intensive care, if they don't land on intensive care unit, but even the moderate cases, maybe those who stay at home. Does anybody have any information here? Maybe I'll ask Balil, maybe you want to mention your experience, or what are your thoughts on this?
Yeah. So lung fibrosis from recurrent bacterial pneumonias has definitely been documented. But looking at the number of people who get the influenza infection, I'm not familiar with any data that tells me that a viral infection, whether treated or untreated, which we can talk about, would lead to any residual fibrosis in the lungs. Even the treatments that they've come up with in the U.S., we're looking at remdesivir, hydroxychloroquine, zinc, azithromycin. None of these have really shown any potential benefit in a clinical trial yet. In vitro studies have definitely shown some theoretical evidence that these may help, but I'm not necessarily sure that this virus would cause lung fibrosis. If it does, we'll find out in the future.
Thank you very much. I think from my experience, or at least what I've heard from some of the doctors who've treated, yes, they've seen cases of lung fibrosis, but the data will have to be looked at, especially after some months and years, because we do not know what will happen to some of these patients many weeks and years down the road. There is some data that shows that patients after COVID have impairment of lung function, but we'll have to see if that is something which will turn into a chronic problem, or is something that will alleviate, or will, of course, come back to normal after some weeks and months. There was a question out there, maybe I'll ask Martin that, since he's working with such patients. Is lung transplantation in COVID-19 an option?
It is a very tough question, because I'm not the surgeon who is deciding who gets a lung transplant overall. But so far, I don't think there is any data available. Sorry for this brief answer.
I think it definitely is something that would be very difficult to manage in this situation, because you're not getting rid of the infection. The patients are still infected. You have the immune suppression. I do not know if that would really help the patients, or if this just is a little bit over the top, in the sense of the global problem we have with some patients not even having ventilators, while other patients get lung transplantation. I personally don't know of any case that where someone has undergone lung transplantation. But does anybody else have any ideas on this?
The ISHLT guidelines actually recommend to not transplant anyone with an active infection. So if they were to receive a lung transplant, it would be after they had cleared their infection and had still required chronic oxygen therapy, or they're just not getting better from the illness that they had.
It's a very clear statement, and I would completely agree with that. In this situation, it's a little bit, I would say, a risky procedure. We get some questions about disinfection from Ursula. She wants to know, how do you disinfect actually probes, and what kind of what substance do you use for the instrumentation, for example, also for the point-of-care ultrasound device? Maybe I'll ask Jean-Jacques.
Yes. Very easy. You use your common hydroalcoholic solution, and then you just clean all the surface. So it is very difficult for bulky ultrasound devices, because you cannot clean all the surface. It's very easy with a pocket-size ultrasound device, and you can repeat as many times as you want the ultrasound examination on the same patient, on a different patient.
Thank you very much. There's a question coming in about the whole issue of isolation, and when can we get the people out of isolation again. And one of the questions was what should you do? What kind of test should you run? And what if a test is negative? Can you actually release the patient from isolation? This is a question from Samantha.
So how we do it with the immunosuppressed patients. So all the patients we are tested, and they have to be tested negatively. So we cannot risk to have a COVID patient combined with lung transplant patient. But if they are tested very, very early, we do isolate them for, depending if it is immunosuppressed patient, it is now the guideline that we at least test again after 6 days after the last documented contact with a COVID positive patient. And if that is negative again, and always just the PCR, the patient can be, the isolation can be withdrawn.
Yes, I think that's it. It centers around the question of how long is someone infected, how long does still someone have virus load, and I think some of these questions are still open, but I guess you need a certain margin until you can really release these patients and of course not risk him from infecting someone else. Fadi is asking the question is why in the Middle East are there so few patients, or why? What is the reason? Is it the weather? Maybe Bilal, maybe you since come from a state where it's rather hot in Texas, can you kind of relate to that somehow?
I don't think it has anything to do with the weather. I might be wrong about this, but viruses survive in very extreme conditions as well. I think it's all got to do with how humans interact with each other in every space and where you travel from and where you go. I know I spent a lot of time in Dubai in the UAE growing up, and I still follow quite a bit of stuff over there. And the way they have shut down that country to limit exposure and spread of the virus is probably one of the most robust that I've seen so far.
Yeah, I definitely believe also that it is also a matter of how the country manages these patients. But the issue of temperature is a very important one, because there's always the hope that it's a seasonal problem in Europe, that soon, if spring finally comes, weather is starting to really get better, I must honestly say here, that it will also take the COVID-19 infection away. There are, at least in my knowledge, a few publications that show that, yes, temperature and the humidity of the air plays a role, but if it will be such a difference, or if it really has the magnitude to alleviate the problem, we honestly do not know. We can only hope that it works, but as mentioned, since you have it in areas where it's rather hot, I would assume that it is not the only factor that plays a role, and probably it is very much related. Please.
Yeah, one of the things that I would add is that, so if you look at the flu virus. In the winters, the flu becomes a lot more of a problem, is because people isolate themselves into indoor spaces. We're a lot closer to each other. We try to avoid going out, and the spread of a flu virus is a lot easier to happen in a colder climate or environment, where when you're in a hot environment, you're actually moving around a lot more, and that may have something to do with restricting the spread of the virus by us not being confined into smaller spaces.
Yeah, okay, thanks. Thanks for clarifying that. There's a question that comes with respect to kidney function. We know that many patients have kidney function, and the question was if it is related to the viral infection itself, or is it a phenomenon in the sense of multi-organ failure, which is related to hypoxia? Maybe I'll ask Jean-Jacques, are you seeing patients?
At the admission of the patients, the viral quantitative analysis shows very high level. 7 days later, the viral quantitative analysis show very low level. But despite of this, the patient does not improve or even worsens. So the idea we have is that at first the virus is making an injury to the lung, and very soon an inflammatory storm made of inflammatory cytokine is injuring the lung. So the kidney disease, the creatinine level is a marker of death. It predicts the the death of the patient. It is clearly demonstrated in a Chinese paper. So very likely, acute kidney injury is related to the inflammatory storms rather than to the injury made by the virus itself.
Yeah. Thanks for your answer. Regarding the last question we discussed with respect to temperature, we got a comment from Tim, and he is from the Middle East, and he mentioned that the population is rather young in these countries, which might also play an important role. And of course, as you mentioned as well, that you have very strict isolation measures there. He does not believe that the temperature plays an important role. So thanks for your comment, Tim. I think this is also very important that you contribute out there to this discussion. One question that we get regarding to the heart is pretty much related also to what we just discussed with respect to the kidney, but I'd also like to have your take on this. Is what about the role of the heart? Is the heart an important factor in mortality? Because we do see data that shows that a lot of patients have a cardiac condition which is the cause of death. Is it a secondary problem? Do the patients have, again, viral myocarditis, or is it just because the people have multi-organ failure? Maybe I'll ask Bilal, maybe you can give me your point on this or your thoughts?
So there are very few reported cases of cardiomyopathy that are related to COVID-19, but it's rare, but it's definitely been seen. In my opinion, and been doing critical care for this long, being critically ill is the stress challenge you can take. If you have a bad heart and you get critically ill and you survive a critical illness without your heart getting injured, your heart, it tells me that a lot of things in your body are doing okay from a heart standpoint. So people who are getting heart injury from a coronavirus infection, they probably already have underlying coronary artery disease, and this is how it's being he's manifesting during the critical illness.
Well, I think that is a very... Please, Jean-Jacques, maybe, what are your thoughts?
Yes. You know, in the Wuhan cohort, the high-sensitive troponin level at admission was predictive of mortality. And the change of the troponin level, the increase in the troponin level according to time, was a high predictor of mortality. So I would say that according to the data we have, it seems that the virus is injuring itself, the myocardium, because initially the troponin level is higher in patients who are going to die compared to those who are going to survive. So I think that the viral myocardiopathy is a real problem and a real injury resulting from the virus itself. But we need more data.
Yeah, I think there's, of course, the concern that we have vascular leakage, capillary leakage, just as we have it in the lung, also in the heart. And I've heard reports of myocardial swelling. Maybe this is related to the virus. All too early to say. Definitely patients who have a cardiac condition are at higher risk. And most likely it does affect the heart either indirectly through the cytokine storm or directly by the virus. We do not know. I guess these are some of the things that we hope to clarify. Very last question is related to the question of what kind of masks are there and what should we be using. I have prepared a slide because we got that question up front. I just want to maybe comment on that very briefly because there's a little bit of confusion out there with respect to what we should actually be using. And the big important thing is, if we can maybe show the slide, yeah. We've got the surgical mask, which is something that we use to actually protect the patient from us. If we do, for example, a surgical procedure, while we have the so-called N95 respirators, or in Europe we call them FF2 or 1 or 2 or 3. Those are protective mask devices which have a higher, I would say, filter rate, and where you can filter out very small particles and therefore have a much higher safety for protecting ourselves or the healthcare professionals from the virus itself. So these names, the N95 and FF2, what they basically mean is they mean how much percent of a particle, a certain size, they actually filter out. And there's a different scale. One in the US, they use the N95, and the Europeans use the FFP scale. So basically both the 2 and the 95 are probably sufficient, and all the other things are probably something which are not really applied very much in medicine. They're even have even higher filter rates and are not the things that you should be wearing. But basically it is generally recommended that if you work with patients directly with COVID positive patients, you definitely need the FFP2 masks. And there's of course a lot of controversy whether or not we should use the surgical masks or not in certain situations and where they should be used. Any comments maybe from the panel?
So in the United States, we're using N95s or PAPRs. We have these PAPRs that are almost like helmets that have a face shield and a respirator on them. Those are pretty much reserved for any patient who's at risk for aerosolizing their secretions. So people who are intubated, getting CPR, nebulizer treatments, either on high flow nasal cannula or a very rare instance using non-invasive ventilation. But all the other patients, even if you're being tested for COVID-19 at this point, you would get N95 and a PAPR. But if you are not diagnosed, if you are just being tested right now, you would only be in a surgical mask and a gown until your test comes back negative. And that's in part a measure from data, but also to try to conserve the supplies we have.
Okay. Well, thanks for adding even more information to this topic. I think we slowly need to get to an end. We are now over, I think, 2 hours. We've reached almost 13,000 users. I know there's many burning questions. For those who are interested, there is a platform that we founded as well where we are trying to answer all the questions that we get from the webinars. It's an FAQ platform called Doc19. Just enter it on the internet, doc-19.com. You'll also find it on our main webpage, which I'll introduce to you just briefly a little bit later. I just want to maybe just end with just a few comments that are very important. Of course, Jean-Jacques has a very important publication out there, which I do want to highlight. It's a publication, if you can just show the screen shortly, in anesthesiology about lung ultrasound. And if you want to see his presentation, if you go to the second page of this publication, the link is actually provided on our webpage as well. You will see certain URLs which you can just click on, and you can download the presentation from Jean-Jacques as he presented it today. So I think very valuable information. You can get it from our downloadable PDF under the Q&A section of our webpage. So this is the webpage that I've been mentioning. It's just the same webpage that you're now in, except that it doesn't have the ending web at the end. It's the COVID-19. That's a webpage we founded where we will put all sorts of relevant information for healthcare professionals out there to combat the battle against COVID-19. We provide information, just mentioned the FAQs, but also lectures, and that's exactly also where you'll find the free lecture that we just produced jointly with Martin and with GE. I'll just give you a very short trailer that you see what the video looks like. So let me just go back to that. Yeah, so and finally, I think I just want to mention a few things which are very important on my mind. Of course, condolence to all of those who were victims to the virus in the medical healthcare professionals. I mentioned already the president of the European Society of Cardiovascular Instruments, to his relatives and to his family, of course. We do hope that we can end this battle soon and that we do not see many more victims in the medical community. I can only say protect yourself. Try to, of course, obey to these measures that are so important. We'll try to add with some information on our webpage as well. And I think one maybe message to the healthcare providers that I do want to say is, and it's a statement from a colleague who is very strongly involved in the World Health Organization, and he was one of these people who were instrumental in fighting the battle against Ebola. And when he was asked what he thinks is one of the most important key learnings from the Ebola, it is be fast. And I think that's something that I do want to end. And I want to thank you out there for your, of course, support and for being with us, for watching this webinar. I want to thank every speaker that was with us today, from Paris to Dallas to Vienna, and of course to China, who supported us very much as well. Thanks again. Thanks Jean-Jacques, thanks Bilal, thanks Martin, and thanks to you again.